I'd like to introduce. Okay, we'll see you soon, Atul. Okay, Roberto is a neurosurgeon from Argentina.
Thank you.
Very good. Okay, Roberto. Yeah, Roberto is a neurosurgeon from Buenos Aires. He's done a lot of education. He has a conference scheduled on the 26th of this month
Thank,
on neuro-oncology in Spanish. And I'd like to introduce Roberto. Welcome, Roberto. It's all yours.
Yeah, good morning, everyone. It's my turn now.
Yes.
Okay, I'm going to share the screen. Can you see it? Yes.
Yeah, you're gonna put it on presentation mode. Yeah, in the screen. Yeah. I think, yeah, reproduce. Yeah, you had it. You had it. Reproduce. Yeah.
Yes.
Yeah.
It's okay.
Yes, perfect.
Uh, okay. First of all, thank you, my good friend Sameh, for inviting me to this glioma session, amazing glioma session. I'm going to talk about what I think that it is the future, will be the future in glioma surgery. This is our clinic in Buenos Aires, Argentina. And Argentina was the fifth country in the world where we operated a brain glioma using intraoperative MRI. And behind United States, Germany, Finland, Canada, and the fifth country was Argentina. We operated the first glioma with intraoperative MRI on July 2000. Recently, last year, we published part of our experience. And between July 2000 and December 2004, near 1,000 patients with glioma were operated using intraoperative MRI. It is a great experience, and we learned some tips about glioma surgery. And we used to navigation, brain mapping, away surgery, other tools to operate the gliomas. Some lessons we think we have learned. One of the most important is that the tumor doesn't have any neurological function. A ver acá, espera. Cambiar. Ahí está. Okay. We never found neurological function inside, within the tumor. I'm going to show some examples. This patient was operated in 2006 of this central area glioma. And in the beginning, we used brain mapping, electrocardiac stimulation, but not in the last 10 years. And we removed this using intraoperative MRI, and you can see the result. If you remove completely the tumor, this is the result. This is the patient with completely normal life, almost 20 years after surgery. This huge tumor, a big tumor, we decide to remove it, and you can see this tumor, and this is the surgical field, and this is the postoperative MRI with very good resection, with radiotherapy, chemotherapy posterior to the resection. But this is the patient right after the operation and 6 months after the surgery, with 3 years after surgery of this big tumor with no remnant, and the survival of the patient more than 3 years after that surgery. The tumor is not an eloquent area. This is other thing we said. We never found eloquent area on functional area in this area, in the tumor area. The activity of the function are around the tumor, never into the tumor. You can see this Broca area tumor here, this tumor. We decide to operate. This is the brain surface. And this is intraoperative MRI after removing completely the tumor. And this is the patient 10 years after surgery with no language problem, with no tumor, with no remnant, with no regrowth of the tumor, and with life completely normal. This low-grade glioma was located in pars opercularis. We decided to operate only using intraoperative MRI. And here you can see this is the head is still open. This is the resection of the tumor. Here you can see intraoperative MRI, the surgical field after removing the pars opercularis, and the patient talking immediately in the postoperative with any language disorder, completely normal. Other lesson we think we have learned is that using intraoperative magnetic resonance imaging, we can do complete and safe removal in low-grade gliomas and in high-grade gliomas too. You can see this patient. We can operate away this patient with 82 years old with this frontal glioblastoma. And we decide to operate with intraoperative MRI. This is the first control with this remnant of tumor here. This is the sagittal view, axial and coronal with this remnant. We can see clearly this remnant of tumor here. And this is the last MRI with no more tumor, complete gross total resection. And this is the patient 26 months after surgery, fully recovered and without any neurological dysfunction. I think the brain mapping is not the solution. Away surgery cannot be considered the gold standard in glioma surgery for a very simple reason. Most of the patients cannot be operated away. There are a long list of the patients that we can't operate away. And in the most cases, there are remnants of tumor that could have been removed, but the surgeon didn't see using away surgery. For example, in children, the glioma is the solid tumor more frequent in children. We operated this boy in 2009 with this insular glioma. Here you can see the baby. This is the first intraoperative MRI control with this remnant of tumor and flare. And this is the last. Here you can see the head is open. This is the patient a few days after surgery, completely normal. And this is intraoperative MRI with no more tumor in insular region. And this is the same boy who nowadays he is completely normal, and it is 15 years old boy, completely normal. You can't operate away mainline tumors. In this case, it was pilocytic astrocytoma. We decided to operate with intraoperative MRI plus neuronavigation. And neurosurgeon can recalibrate the neuronavigator with image obtained in real time and avoid the brain shift. And this is the result, complete resection of the midline benign low-grade glioma. And in 64% of the case, there were tumor remnants using a weight patient technique, and there are a lot of papers like this. And we don't have to forget the complication, the adverse events in a weight craniotomy. I think this is not the solution. But by the other hand, the high field, the intraoperative MRI, is also not a good solution with the equipment currently designed. To put a high field intraoperative MRI in a clinic, in a hospital, requires large areas and very expensive building walls for installation, only for installation one of these devices. And you can see this operating theater with this 15 tons of magnet coming toward the operating room, hanging from the ceiling. It is almost crazy. And it is very expensive, impossible to do in around the world, in different countries with different economic acquisition. But the main problem with high field MRI is this. You have to test with a ring to see if the patient can be introduced into the magnet. We need, you can see here, 1, 2, 3, 4, 5, more than 10 people to move the patient to the magnet. And then the patient must be moved back to the operating room to continue with the surgery. I think this is the main reason because the high field MRI is not good for check, for test the step of the surgery. We need this, but we can do this tractography, spectroscopy, functional MRI before the surgery, no into the operating room. We will see in the near future different devices, new devices that will be simple, practical, easy to use, fast, neurosurgeon friendly, and the most important, machines that MRI that respect the condition of conventional neurosurgery. This is the device we are using in the last 2 years. Have been using in the last 2 years. Here we are doing the craniotomy. In a few seconds, with a simple rotation movement of the stretcher, we put the patient in condition to achieve MRI. I'm going to show, for example, this low-grade frontoinsular glioma. Here you can see the first control with this remnant of tumor here. The second control is a thin layer of tumor remnant here. And the last intraoperative MRI with no more tumor, a complete and safe resection of the tumor. And this is the postoperative high-field MRI in T1 and T2 with complete removing of the tumor. And this is the patient completely normal without neurological dysfunction, and this is her surgical bed after removing the tumor. Intraventricular glioma, you can operate this. You can use fusion of images, and here you can see the tumor before and after removing. Fusion of image here, the approach, and this is postoperative MRI with no remnant of the tumor and the patient completely normal. Low-grade glioma, parieto-occipital tumor, we can put the patient in prone position. You can use neuronavigation. You can use the normal microscope. And this is the intraoperative control with the mark at the bottom of the cavity with this gross resection. And this is the postoperative high-field MRI with no more tumor, and 2 months after surgery, the patient in completely normal life. we think that this is not the final evolution of glioma, mainly in low-grade glioma surgery. I'm going to show you some surgical cases, but because we think that in low-grade gliomas, gross total resection could be the cure of the patient. You see this tumor, frontal lobe tumor. This is the resection, intraoperative MRI with this remnant. We go for the tumor, remove the tumor completely. This is the patient 18 years after surgery with this gross total resection of the tumor and completely normal life. This patient was operated in a 9-year-old boy, operated on July 2001, 7 years postoperative, and this is the patient 23 years old after surgery. A good surgery, we think, could be cure the patient, and the intraoperative MRI could be the best tool to achieve this goal. This is a case in a patient with two tumors, one on the left temporal right and parietal left lobe tumor. We operated temporal lobe, then the parietal tumor. And this is the patient 7 years postoperative, 10 years, 14 years. This is the patient nowadays, 18 years postoperative with his family. And this is the last MRI, October 2024, with two tumors operated, only with MRI imaging guidance. Premotor area tumors operated 2010. This is the control 2014, and this is the patient 14 years after surgery here with her family. Another big tumor, gross total resection guided by MRI with no more tumor. 15 years survival without tumor. Butterfly wing glioma, high-grade glioma, operated. This is the patient immediately in the post-operative, very good resection, 3 years survival. Glioma, temporal lobe glioma, operated 2005, 19 years post-operative with no glioma. It is very important to remove completely. And the difference is significant. It's very important. You can see here this tumor operated in another country with this remnant here. We decide to reoperate this patient and remove the tumor. You see the baby 1 month after surgery, 10 days here. And this is the MRI. Nowadays, at the present, this is a very nice lady, 19 years post-operative. It's not the same. This partial resection, that complete resection in low-grade glioma. A few months ago, Professor Michel Berger visited Buenos Aires, Argentina, and he said that the future of glioma surgery will be image-guided navigation. And he talked about low field magnet that he expects to have available within 3 years, and low field MRI into the operating room. This is other device that is used by Professor, my friend too, at Herrera in Aga Khan University. Different devices are in develop now. This is 0.064 Tesla. Professor Sameh Professor Sameh said that nobody want to be operated for a glioma without having the control during their surgery. Therefore, we don't need to discuss about if it is necessary or not necessary. If you have it, said Professor Sameh, you have advantages. And if you don't have it, you can change this and you can do away patient surgery, whatever is possible you can do. And Professor Jasserkill said in his last book, Neurosurgery, in 4 volumes in 1994, the time will come when the neurosurgeon may, in the operating rooms of the future, monitor whenever he needs it with images in 3D the step of each surgery. I think the new conception in the develop of new MRI devices will be in the way of the future, talking about the glioma surgery. And I think it in the next years in advance, in the most of the operating room around the world, we will see small, low field intraoperative magnets to check the step of the surgery in glioma surgery. Thank you very much for your attention.